And we are live. Good morning. Good morning, everybody. This is Sarah Merritt, broadcasting to you live from Lifestream Health Center, where we are making pain management care caring, accessible, patient-centric, and evidence-based. I've got another physician friend and colleague, Dr. Teresa Anderson, with us today. Hello. Teresa Anderson is a psychiatrist and treats patients in Ohio. So while she's not local, she has, to my patients here in Maryland, she has a lot of knowledge, and she practices really in a very overlapping space with the work that we do at Lifestream, trying to help people feel better. So thank you for joining us so much, Dr. Anderson.
My pleasure. Thanks for having me.
And so I would love for you to share a little bit about your practice and what you do in general. I think specifically we really want to dive in on ketamine infusion for mood in particular, and the special therapy that you have that not many doctors have called PrTMS.
Absolutely. So, Teresa Anderson, I'm based out of Cincinnati, Ohio. We work at the Anderson Clinic, and we specialize in treatment-resistant depression, anxiety, and PTSD. There are sort of three prongs to our clinic. One side is the traditional psychotherapy and medication management, and another side is ketamine infusions for treatment-resistant depression, anxiety, and PTSD. Another is PrTMS, which is a personalized EEG-guided version of transcranial magnetic stimulation.
Very cool. Very cool. And tell me about, I guess we could start with either one of these therapies. You know, what patients are a good candidate for a ketamine infusion? I mean, I would imagine in your practice, like you said, you have kind of a traditional psychiatry practice. That might be how some patients come to know you. And then how do you figure out which of these kind of newer or more advanced therapies are going to be helpful for people?
Absolutely. So for ketamine, the person who is acutely suicidal, who's wanting to try to avoid a hospitalization, person who has had decrease in functioning or activities of daily living, they're not taking care of their bills, they're not able to attend work, they're not going to social functions, they're isolating themselves. And people who have tried and failed 3 or more antidepressants or combinations of mood stabilizers and atypical antipsychotics, and still it hasn't touched their mood. Those are the folks that are really great for ketamine, because it's a rapid acting antidepressant and it can really sort of lift them out of the abyss. Nothing's a panacea, obviously, but it can sort of lift them out of the abyss long enough to get the behaviors and activities going that might further the cause of sort of reinforcing that positive neurochemistry, right?
Mm-hmm. And here's a question too. I have a patient that I've treated recently who does have significant treatment-resistant depression, but she has really a lot of anxiety, and her maybe anxiety scores are even higher than depression. Is that person a good candidate for either or both of these therapies?
Absolutely. Absolutely. We've even seen folks who go to the ketamine for an acute sort of just alleviation of some of the anxiety, and then move on to PrTMS for a longer term alleviation of the anxiety and depression. And that's one of the big things for PrTMS is it tends to have a longer durability, like staying power, than the ketamine does. So for ketamine, folks will feel better for maybe weeks to months. For PrTMS, it's more like 6 months to a year that they are feeling better and are kind of solid, steady, and stable. Especially the folks who might have had an undiagnosed concussion or traumatic brain injury.
Yes.
You know, the brain is like unset jello. And so any hard stop is going to put some sheer force and strain on the neurons and slow them down. And so I can't tell you, I've had at least a half a dozen of my own patients where we literally threw every medication at the book at them, and it just wasn't touching it. And when we did an EEG, found that they'd had undiagnosed concussions, and that was what was slowing their neurons down. And their brain, essentially in different parts of their brain, was sort of speaking a different frequency. They weren't on the same walkie-talkie frequency, essentially.
And an EEG can diagnose a concussion, is I think what you're saying is one way.
This is a specialized version of an EEG. It takes all the data that comes out in like gigantic rolls, and it compresses it into one page that's easily readable. And Dr. Kevin Murphy, who created this technology in San Diego, he found a way to compress the data, and after several thousand EEGs, started recognizing patterns among different diagnoses. So much so that you can actually see patterns for bipolar, patterns for concussion and traumatic brain injury, patterns for insomnia, patterns for depression, anxiety, PTSD, OCD, ADHD, sociopathy. Like last year, it was even set up as an FDA approved diagnostic device because it's so like on the money.
That was what I was going to ask. Is like, can you make a real diagnosis from that, or do you need more? Like it's going to clue you in, but it is sufficient now, I guess.
We always take the clinical history, but we also, based on the clinical history, give certain neurocognitive exams. And so for PHQ-9 for depression, GAD-7 for anxiety, PCL-5 for PTSD, Rivermead post-concussion scale, there's an ADHD scale, there's an autism scale, there's a bipolar scale, there's scales for everything. But whenever we give the EEG, which is once a week during treatment, we repeat those scales that's appropriate to the patient and sort of monitor those numbers going down.
Wow. That's very interesting. And so TMS stands for transcranial magnetic stimulation, correct? What's the PR of PrTMS?
Personalized, repetitive, transcranial magnetic stimulation. Yes. So in standard TMS was developed 15, 20 some odd years ago as a kinder, gentler version of ECT, electroconvulsive therapy, or shock therapy as it's colloquially known. And so the idea being that you're creating a magnetic field around the skull, and once it passes through the skull, it turns into electrical energy. And as it's turning into electrical energy, it's trying to sort of reset the neurons at 10 hertz, which is the average standard adult human alpha wave. 10 hertz means that you are sampling the world around you with all of your senses 10 times a second. But Dr. Murphy found that, this type of treatment isn't specific to the person. It's sort of a one size fits all treatment. And if you can find a way to personalize it, find a person's innate alpha wave rhythm, you can actually hone in on that rhythm and amplify it. So what if you run better at 11.5? What if I run better at 9.1? It doesn't seem like that much of a difference, but actually tuning the machine to your brain's inherent alpha wave frequency can actually make your brain run better instead of trying to retune it to a sort of arbitrarily chosen average alpha wave.
Got it. Yeah, and that makes some intuitive sense to me, just that there might be different norms in different patients, and they're all going to be within a range, but we all have differences, right? And there's no one like, hey, we're all going to function on this exact clock and be the same. That's just not how humans are.
Absolutely. And because we can focus in on the frequency of a person's inherent alpha wave, we don't have to use such a high amplitude like standard TMS does. And so we can actually place it right over the motor strip without fear of causing a seizure. We can place it right over the emotional centers, right over the executive functioning and attention centers. We can help with sleep. So we sort of look at our treatment more like a sniper instead of a bomb blast. And it's, less collateral damage and very personalized, very specific to the unique individual.
And it's really tuning into that alpha wave. That's interesting. And so the alpha wave, for folks that are watching, the alpha wave is kind of your resting state of the brain, right? If there are bunches of different waves that occur in the brain at different points of wakefulness, and you correct me if I'm wrong, but that alpha wave is kind of the happy background, the relaxed background.
If your engine's idle, essentially.
When your engine's idle, there you go. And not necessarily, I'm probably not in alpha waves right now so much. I'm
you're in beta.
Camera, I'm thinking, I'm talking.
Yep, you're in beta.
So when we're sleeping, alpha for me.
Yeah, perfect. When we're in delta, we're sleeping. When we're halfway between sleeping and wakefulness, we're in theta. When we're awake and alert but not interacting, sort of in the meditative, prayerful position, we're in alpha. When we're interacting, we're in beta. We're being chased by a Bengal tiger, we're in gamma. So we hope that people aren't, that level of excitability. But for the most part, when you're interacting, you're in beta.
Got it. Yeah, that's super interesting. Because I think it's like that resting state of the brain that we all have to like go to in life to have some reserve to be able to function, right?
Mm-hmm. And there are actually ways that you can improve your own inherent alpha outside of PrTMS.
Thank you. Let's talk about that.
Yeah, if you meditate and while you're doing the treatment, you can actually improve your treatment outcome doing this too. Is you can meditate, you can pray, you can do repetitive exercise, and we're talking about the kind of repetitive exercise that you can kind of go like zone out. Like swimming, for instance, is a great one because you have to think and breathe and move, and you're moving at the same time over and over and over again. Elliptical,
cycling on the trainer.
You're getting all of your limbs moving, but it's in a rhythm, and you can kind of zone out and zen out in essence. So all of those things can put you in an alpha wave state.
That's super interesting. Yeah, and so and I think that's really practical. Right, we talk about improving mental health, or what are the things we can do for ourselves to have a better life, to function better with pain. Like these are things I want to, offer to our people. And absolutely, there's other ways that you can improve your alpha waves, improve your, how you function at baseline with all those things. That's all also so valuable.
Absolutely.
Tell me about a patient case. I would love to have you share, and I guess really with either of these therapies, but tell us about, a way that your work has made a difference for the patients that you treat.
Sure. We had a gentleman who came in with a posterior circulation stroke. So he had bilateral vertebral artery dissection. So the fact that he was alive was impressive, but he went from a normal adult functioning, has a job, has a family, has a life, to in a wheelchair, barely muttering answers, half asleep when you talk to him. This person had the worst EEG I'd ever seen in my entire life. So when we see EEGs, we are hoping the alpha wave kind of rests in between the 9-ish to 11.5-ish range, in terms of hertz frequency. Anything below a 8 kind of puts you at risk for dementing illnesses. For instance, if you had multiple concussions, like, chronic traumatic encephalopathy, like the pugilists, the boxers and whatnot. Right. Anything below an 8 can put you at risk for dementing illnesses, regardless of the cause. Chronic use of Benadryl, chronic use of opioids, benzodiazepines, all those things can slow you down. Traumatic brain injury too. But when we first saw him, he was at a 4. Like,
way out there.
Just above comatose, essentially. And his treatment went on a lot longer than the standard treatment went on. We typically treat between 6 and 8 weeks, a little longer if the problem is complicated. So if you have depression or anxiety or PTSD, it's like 6 to 8 weeks. If you have multiple things plus a head trauma, it's probably more like 2 to 3 months. This gentleman treated with us for 6 months. And we brought his alpha wave up to an 8 hertz.
Wow. So doubled.
Yeah.
My gosh.
And he's talking in short sentences now. He's using a walker. He's joking around with the staff. He's awake and alert for most of the treatment. And we're, before he was falling asleep in between sentences. And so, this is huge, because I essentially, I am never one to lose hope in general. I'm not a Pollyanna by any stretch of the imagination, but I'm never one to lose hope. This is the first time I ever told a family, I don't know if we can help him.
Right.
I don't know that we can see any sort of results. But like, no, we're going to try it. I'm like, okay, well, just so you know, just a caveat being, I don't know if we can help it. And we have.
Wow.
So that's huge, huge. Another lady was a retired teacher and had done ketamine before to really good effect. She'd been on multiple medications for 20, 30 some odd years with a history of long-standing depression. She had a recurrent episode of depression and waited a little too long to come in to do the ketamine infusions, and they didn't touch her. And so we said, just give the PrTMS a try. And she's like, she wasn't willing to commit to 6 to 8 weeks because of finances, and she wasn't willing to commit that long because you really wanted to die, in essence.
Mm-hmm.
I said, give us 2 weeks.
Yeah.
You owe your husband that, and he loves her. He was, very supportive spouse, and so she gave us 2 weeks. And in 2 weeks, she was going to the gym. She was wearing makeup and fixing her hair again. Decided, okay, maybe 6 weeks won't be so bad. And then, so we got all of our scores in single digits by the time she left. And she went from planning her funeral to planning a Caribbean vacation and second honeymoon with her husband.
Wow. My gosh. Yeah. What a big difference maker. And then, I know no two cases are the same, but it would be typical for those types of responses to last 6 months or a year.
Mm-hmm. After the initial treatment, we do a 3, 6, and 12-month EEG follow-up just to see, check in with the patient and see how they're doing. And obviously they can come in sooner if they have symptoms returning. But for the most part, it lasts a good 6 to 12 months or more. Mm-hmm. People come in for like maybe a week or two tune-up every once in a while, but some people can minimize their medication schedule, and some people can't. But a lot of folks can simplify it and don't need nearly as much treatment with the PrTMS on board.
Yeah, that's super interesting. Yeah, I would share that one of my current, I do some ketamine infusions for pain and depression. Mm-hmm. I do have a patient that I'm treating currently for mood, and she's had good results. But she really describes that she had an ECT treatment that she got 10 great years out of, that she was very pleased with, and but just was hesitant to go back. And so that was how she got on this path of trialing ketamine infusion, because it was new for her.
ECT is fantastic. I mean, it has a 70% efficacy, but along with it can include a lot of short-term memory issues that never go away. Yeah. So I tell folks, before you go that route, at least give PrTMS a try.
Yes. And so PrTMS is associated with less memory loss or no memory loss, or do we know?
No memory loss, and 3 to 4 times the efficacy. So Dr. Murphy recently submitted a paper to one of the national outfits, and they had done a side-by-side retrospective comparison, standard TMS to PrTMS, and it was a cohort of VA veterans, and they used the PCL-5 as a scoring guide to measure the level of trauma. Yes. And so in 6 weeks, the standard TMS dropped their scores by 22%, which is great. Yes. PrTMS dropped them by 88.
Wow. Yeah, that's a big, which one do you want? I want 88. Yeah, that's a big difference. And it appears to be as durable or similar durability to the regular TMS when it's been compared, or does regular TMS quote similar numbers for 6 months to a year of durability, or not even? Oh, no. Okay.
It's a 30% efficacy. And I don't know why, but I'm theorizing because it's not, if you are one of the lucky individuals to have that average human alpha wave of 10 hertz, it's great. But if you don't, then it may not be tuned into your brain.
Oh, that's interesting. Yeah, that makes sense. Yeah. Is that your norm, or is that somebody else's norm that you're getting tuned to? Yeah, that's super interesting. How long have you been offering these therapies in your practice?
So I've been in practice for 13 years, and I've been offering the ketamine infusions for 7, and PrTMS nearing 4 years now. Great. We're one of 12 in the nation offering it right now.
Yeah. So you're pretty early on board with the PrTMS technology, it sounds like.
Yeah, Dr. Murphy was not planning on expanding to Cincinnati, but one of my patients happened to find him
Mm-hmm.
looking for a treatment for her autistic kiddos. And when she came back, and she's bipolar herself, and when she came back into treatment, she had decreased her medications by half and was sleeping through the night. Her kiddo, who wasn't verbal, now wouldn't shut up. Her kiddo, who was completely uncoordinated, was now riding a bike. I'm like, who the crap is this guy? I got to meet him.
What is this? Yeah. How interesting. How interesting.
Yeah.
Well, and I'd be interested too, as we're thinking about ketamine, some of our viewers might be interested in that therapy. Controversial topic, ketamine lozenges at home. There are places offering this services. There are times that they've even been prescribed in our practice for the right patient. Is this something that that your practice does, or what do you think are the caveats or the problems with that?
So we don't do anything but intravenous ketamine.
Mm-hmm.
A couple of reasons. The intranasal doesn't seem to work as well, and it's just part of the bioavailability, right? If you inject something into someone's vein, it has 100% bioavailability, and if you are squirting it up your nose, who's to say your nasal septum is thicker than mine, or did the thing misfire, or did you swallow or inhale some of it? We don't know exactly how much you're getting. So it's more like a 60 to 70% bioavailability. So you have to increase the dose. So anytime you change the route of administration, you're going to change the bioavailability. And so if the bioavailability goes down, you have to increase the dose to make up for it. Same way with lozenges, oral, troches, intramuscular, all the things. And so your liver is going to chew up close to half of that dose if you're taking it orally.
Okay.
And so you have to take double the dose, close to double the dose, to get the same effect as you would half that dose intravenously. Mm-hmm. So not only are you going to have increased side effects from oral, intramuscular, intranasal, you're also going to increase your risk for dependency, especially oral. It's so easily, misused, abused. Yeah.
You think it's more risk for dependency partly because of the bigger dosing that's needed
and easier access.
And access.
If you have 5 ketamine lozenges, who's to say, well, I took one, maybe if I took 2, I'll feel even better.
Absolutely. Yeah. That's for sure. That's definitely one of the risks. I think that makes a lot of sense. Well, I think this is a really valuable discussion to talk about some of the emerging therapies for, frankly, difficult problems in psychiatry. And I think ketamine infusion in particular, I think has been heralded as, maybe arguably the biggest advance in psychiatry in decades.
Probably 50 years.
Yes. That to be a real game changer for so many patients. I feel like when I talk to you that the PrTMS results are similarly super robust and also in that game changing area.
Absolutely. And it's especially helpful for folks who either are phobic of needles or who are on medications that are contraindicated for ketamine, like high doses of Lamictal, high doses of opioids, high doses of benzodiazepines. All of those don't play well with ketamine. And so if you're on those things and you can't get off of them, for instance, you have seizure disorder and you're on high dose Klonopin and Lamictal, it's not going to work for you. So PrTMS would be the better option.
Yeah. And tell me about accessibility of these therapies. So I think, we've had challenges with insurance coverage for ketamine infusions. Most practices do those outside of insurance. Is that the case in your practice also?
Yeah, the ketamine is 100% self-pay because insurances unfortunately won't use it or even consider it as a gold standard because it went generic in like the 1970s. And so any pharma company that produces chemicals can produce ketamine. So nobody's willing to pony up the dough to do the randomized controlled trials of a large scale, because if they spend millions, anybody could benefit from their research dollars, which is sad.
And it's really like the process, right? Start the IV, monitor the patient.
Absolutely.
That's where the work is. It's not that the drug is even expensive. It's just that there is like clinician time, which is not very valued, unfortunately.
It's absolutely wholeheartedly true. Yeah, for sure.
And
With
what about the PrTMS also? Sorry.
Yeah, with a PrTMS. So that's tricky. So insurances will say they will cover treatment-resistant major depression, OCD, and migraines. I have not once in 4 years seen them cover for OCD or migraines. But they will cover for major depressive disorder, recurrent severe. They will cover for that if you have tried and failed at least 3 antidepressant agents. They don't include mood stabilizers. They don't include atypicals. But if you've given an adequate trial, which means as high as the tolerable dose that you can stand without side effects for at least 6 to 8 weeks. Or if you tried, say you tried Wellbutrin and had an allergic reaction, that would be considered an adequate trial.
Have to go 6 to 8 weeks.
Yeah. Right. If you tried Effexor up to 150 and it didn't work for 6 weeks, that's an adequate trial. If you tried Celexa for 6 to 8 weeks up to 40 milligrams and it gave you horrible side effects, that's an adequate trial. So that would be.
Yes.
Yeah.
Very good. Yeah. So you've had some success, if for those patients that fit.
They will frequently cover the cost of part, if not all, of 36 treatments, which is about 6-ish weeks. So.
Okay. And so patients are coming in daily.
Monday through Friday. 30 minutes of treatment, an hour for the days that you do an EEG along with a treatment.
Got it. Yeah. So it's a commitment on the part of the patient for getting there also.
Yeah. But I mean, when you consider it, you're not, unlike ketamine, where you are kind of disinhibited and need a driver and can't really do anything for the rest of the day.
Your job for the day
this is like a forced meditation. You actually leave calmer. You could do it on your lunch hour. You could come in before work one day, lunch break the next day, dinner time the next day. So it's based on your schedule, and we have 3 chairs up and running, so we're pretty flexible.
That's great. Well, thank you so much for joining us. This is great information. Is there anything else you'd like to add or make sure that we cover here?
Yeah, absolutely. So if you want to learn more about what we do, you can check us out on our podcast. We are on Apple and Spotify on Psych Waves. If you are in the area, want to give us a call, it's 513-321-1753, or you can reach out to us at www.andersonclinic.net. And if you're interested in PrTMS, but nowhere near the Cincinnati area, you can log on to Dr. Murphy's website, which has a national list of providers, and that's www.prtms.com.
Awesome. Yeah, that's great. Do you have, and actually I thought of one more thing that I like to ask some of our guests. Do you have a top treatment or special tips to stay healthy? What do you think is the most important for people to maximize their mental health at home?
So the biggest things that we've seen create the most impact is having a regular sleep schedule, going without blue light 2 hours before bedtime, having sunlight without glasses, without contacts, without windows, hitting your retina at least 30 minutes every morning between 6 to 9 in the morning, and getting 30 minutes of exercise every day, drinking plenty of water every day, and at some point during the day and during the week, having downtime that's just for you, whether it's journaling, prayer, meditation, reflection, gratitude journal, or it's your weekly walk around the block or walking the dog or going to the gym, making sure that you have an outlet, that you're not just going mindlessly, reconnecting with yourself on the daily in smaller terms, and at least on the weekly, like with a girlfriend or with a friend, or just finding ways to wind down. If you have depression and anxiety, alcohol is not your friend. So it's best to avoid anything that slows down your brain when your brain's already running slow. Fantastic. Thank you so much for all that, because I think that's super valuable snippets that we can all integrate into our day to feel better and live better. Absolutely. All right. Thank you. Dr. Teresa Anderson. I've got her information in the comments. All right. Y'all have a great day.